Welcome to another production by the Millennial Mechanical Therapist. Your hosts, Dr. Joseph Gravino and Dr. Clay Case, are two physical therapists trying to treat health issues mechanically. Listen further for patient cases, guest videos, advantages and disadvantages of the way they practice, and much more. Thanks for tuning in today. Check us out on YouTube, Facebook, and at our website. We hope that you learn a lot from watching this video and you come back for more.
Hello everybody, I'm Joseph Gravino.
I'm Clay Case.
And we are the Millennial Mechanical Therapists, and this is Why We Do What We Do, Part 2.
In Part 2, today we're going to talk about kind of everything else that we went through when we were learning things in school and why we don't really use them too much. Like we said in the first part, things aren't necessarily wrong. We're not here to say that this is the wrong way or that's the wrong way, but we are here to say this is the wrong way for me. Just because sometimes it doesn't flow, it doesn't gel. Like in Part 1, I told you guys, and Joe, the sports mentality just doesn't make much sense to me. It's a long time to get a little bit out whenever I've used it. Maybe that's my own fault. Maybe I'm not using it too well, but I found a system that works really well for me. So we're going to kind of go down the road of a few different styles of physical therapy through this video and kind of talk about why we personally don't like to use them.
Yeah, no, I agree. I think the first, which is huge, is your assessment. Yeah, even in school they teach you, you're good the first day or your first impression of the patient is key to therapy there on out. What you take, what you hear, what you listen to, what you see is going to guide your judgment throughout the entire time you see that patient. So day one is huge, and just from the stuff that we were taught in PT school, the stuff that I've come across in other continuing education courses, styles, mindsets, assessment really wasn't harped on as much as I truly think it should be. No one was talking about how to assess. No one was talking about standardized ways of assessing. If we both could say we're doing the same thing, but doing something totally different under the same overhead of a thought process, and that just didn't make any sense to me, because if we want good outcomes, one, it has to start on day one, and two, we have to have some sort of systematic way of going down and attacking these problems and assessing these patients. Yes, every time you see the patient, you're assessing them, but the first day is huge. That's just going to cloud your judgment if you don't do a good job on day one for the rest of the time you're with that individual. And I don't know any other type of mindset or thought process or technique that really harps on assessment as much as MDT does.
I haven't come across one quite as much. Maybe a little bit with, I read Maitland's books, Peripheral, I think it's Manipulation, I think is his book. I read through that. His assessment chapter is pretty phenomenal. If you guys are looking for some tips and tricks for that one, that's a good one to go with. But his assessment past the history, so when you get into the physical exam, it's very much based on palpatory skills, things like that. It is a manual therapy style, which is, like I said, it's not bad. It's just palpation was not a strong point for me in school. I know that. I remember when we started, we started with cervical. I think that was the first spinal region we had in school. And we had this nice long lab about palpation of the spinous process, the transverse, the articular pillar, this thing, that thing, the other thing. We went through some CVPs, UVPs, TVPs, boopy-doopy-doopy VPs. And
just get lost.
It was all good, I think, but every time I got to it in a clinic when I was doing like a practical setting, honestly, I just defaulted to a symptomatic response similar to MDT would be. So if I ever did manual therapy, I'd go, well, is this making you feel better, feel worse? Which I think is part of the Maitland.
I think so too, from what I understand.
Kind of style, but the palpation type style part of it just didn't flow with me too well.
No, I agree. Unfortunately, even the best palpatory or manual physical therapists, there's little to no, reliability between or intra rate of reliability
Yeah.
between clinicians with that skill, and even the best chiropractors, the best manipulative physical therapists. If you know, I think this is pretty common knowledge by now. You think you may be on L3, but you could be on L1, right? Or L5. You know,
Yeah.
your ability to truly be specific, unfortunately, isn't a good ability. It's not that great.
It's tough.
Not saying that we shouldn't be specific or shouldn't
Right.
try and be specific, right? Or shouldn't think that we should be specific. But if we put all of our eggs in that basket, then we're putting them in a basket that's not too sturdy, if you ask me.
It's so tough because when you go through gross anatomy, we had the fortune again to have, I think we had, what was it, like 10, 12 different bodies in our
Yeah.
class at least, and just the anatomical variation between all of them, and that is such a small sample size, but that shows the
Huge.
power of the anatomical variation in the population. When you see something like that, for me, logically in my head, it just goes, well, you really got to listen to your patient. You can't use your theories and go, I think this one is rotated here and maybe a little bit flexed because I think I feel that. To me,
Yeah.
you really got to listen to your patient. Got to go down to the basis of that. You know, forgive me, I don't remember the exact quote, but I think, was it James Syriac said, if you listen, and I'm kind of ad-libbing a little bit here because I don't remember it exactly, but he said, if you listen enough, your patient's going to tell you the problem.
Yeah, no, I think it was Sirius that said that. No, and I agree with you, and I think anyone out there who's even doing this type of work can say if you get someone with more adipose tissue than normal, it just skews a lot of what you truly are trying to figure out and truly trying to do. And I've
tough.
struggled with that. I still struggle with that, even if I'm trying to take a goniometric measurement, and that person just happens to be a larger individual. It's still tough, which makes it hard. So I mean, I think research out there shows that palpatory skills aren't great. Not that we shouldn't be using them, shouldn't be trying to figure them out, but I think that the good thing about patient response, whether you're using more of a Maitland technique where it's more manual, or whether you're using more of an MDT approach, which would just be slightly more hands-off in the beginning if it's not needed, really allows you to kind of not force yourself to be specific to figure out, but allow you to self-reflect later on. I think that's pretty good about the system, or either system. Actually, someone once said to me that Maitland and McKenzie are pretty similar, except they're on the same timeline, but on the different end of each scale. Whereas Maitland just tends to be a little more hands-on, and McKenzie tends to be a little more hands-off. Not that MDT is hands-off, and we're going to continue to say that.
It's got plenty of manual in there.
One thing that really got me was I bought the OCS one of the OCS study guides, and in there they go through and they talk about a lot of the special tests, a lot of the diagnostic utilities of the special tests, and I was just quite amazed at the poorness, the poor quality of all these tests, and that I was supposed to walk up to an individual, do 3 or 4 tests on their shoulder, and then know what to do.
Got the diagnosis.
When these
supposedly.
tests have so many false positives, so many false negatives, their specificity and sensitivity are never, there's only a few out there that are relatively good, and all the ones that are good, I mean, we back these up on, and I say this to patients all the time, we back these things up on an MRI. And yes, MRIs right now are the gold standard for diagnostic imaging. Unfortunately, just because it's now's gold standard doesn't make it a good gold standard. I mean, since the 1950s, research has come out showing that you can have a torn rotator cuff, any muscle in your rotator cuff that's torn, and be asymptomatic. You could have 5 herniated discs and have no idea.
Do.
Most likely.
Yeah.
I think statistically speaking, in this room, we probably have at least 6.
Yeah. So
that blew
tough.
my mind, right? That we back up these tests, and that's how we're supposed to make decisions. And I hated that. And for a while, I struggled with that. Now, really, how I use special tests is more of a baseline.
I use it as a baseline now.
Yeah, and I really like that. If you ever do take any of the MDT courses, a lot of the diplomats are really starting to push that. If you're treating a shoulder, you truly think it's a shoulder. Something like Hawkins Kennedy's near
I use speeds quite a
few
times.
And you can see some dramatic changes if it happens to be a derangement, but that's a different story.
Yeah, it's really cool when you kind of you clip into that mindset a little bit. On my 3rd rotation again, that was the one that kind of really got me into MDT. I had purchased Netter's Orthopedic Exam.
That's an awesome book.
It's a great book. So I'm flipping through there. I hit a couple patients that I just don't really understand too much because I was still kind of stuck in between where I wanted to go. I still had a lot of school mentality, a lot of that academic background going. So that was very eclectic in a way. It was a little bit of this everywhere. And then kind of deep down, it was like, let's do some MDT. So I get the book and I'm flipping through, and just like you said, I get to some of the pages on those special tests that we're supposed to be using frequently and to help either rule in or rule out diagnoses. And I'm just like, why am I doing this when I look at all the literature? The biggest part that got me is just how contradictory some of the studies can be. At one point you can have a specificity of 0.87, but all of a sudden the next study says 0.2. And
yeah, it was nuts. I've seen seen those like that.
So I get to that, and it helped me solidify the point that maybe I should just use this as a baseline and see if I can change how something moves. And if we take the shoulder again, maybe through MDT I am changing the scapulohumeral rhythm or something. I don't know. I don't profess to be able to do that, but maybe I am, and that's why Hawkins-Kennedy is a little bit less painful after our repeated movements or something. But that's kind of the end of the road that I got to after using MDT and then putting Netter's on top of it, and then just kind of the background from school, because the MRIs just don't mean that much to me when they don't.
Yeah.
They're gold standard diagnostic imaging. They're not really gold standard diagnostic like correlations though.
Yeah.
So it's tough.
No, and I think a lot of research has come out, a lot of things, and a lot of people are coming out and seeing that just because you have some sort of diagnosis, some sort of image that says you have something, doesn't necessarily mean that that's the entity that's causing a problem, nor does that mean that you should specifically treat towards that image. And I think even if you are a little bit more of an individual who kind of lies on the pathway anatomical area, so to speak, on how to treat, even then, if someone comes in with an image, a horrible looking image, you probably don't just send them out for surgery. You try and treat and try and get them done. So I think that even those individuals would agree that just because you have something that shows something doesn't necessarily mean that you need to A, treat that specifically, and B, not be, trust your own judgment. And I just think that MDT allows you to, it just gives you the freedom to take a step back from that, try to assess the patient on your own, use their movement as a guide, and then kind of come back together as a whole and see if does all this make sense? Because all information is useful information, but it doesn't necessarily mean it's going to be useful to treat.
Right.
And
that's the truth.
And all these things we're really harping on assessment, from special testing to diagnostic imaging, manual skills. There's even research out there that supports the use of the McKenzie assessment. Even the assessment sheet itself has been researched more than once. And there's some studies out there that show it's really a really reliable tool. There's some that show it's not as reliable depending upon where you are in your training. But I think that makes sense in anything.
Any method you use.
Yeah, if you were using
not experienced enough.
Yeah, if you were using Maitland for 20 years, it'd be much different than if you started now for your first. So much different. But I think the thing that drew my attention was, at least when I was inexperienced or less experienced than I am now, is the assessment tool MDT gave me. It gave me clarity to step back from anatomical differences, pathoanatomics, from step back from the diagnostic imaging, allowed me to have a tool that was very systematic in how I was going to approach everybody. And that took a lot of the cloudiness away, and then allowed me to learn a lot. I learn a lot from my patients when I can look back, when I can reflect, when I see similar patterns. And because I'm doing things the same every time, I think it really makes me better as a clinician. I think you would agree with that too.
The big overwhelming part of that for me was it's so standardized, which is great for a new grad. I think that is just the number one thing.
I agree 100%.
To make things so much easier in your life as a new grad. As I just said before, when you come out, there are a bajillion things going through your head. You got to remember all these special tests, and you got to remember to check bilaterally, supposedly. You got to make sure you're doing your MMTs the right way. You got to do all of these things that you got to worry about. Then you got to worry about getting the right diagnosis. You got to make sure you get the right prognosis for the patient. You have all this pressure going, And if you have a standardized assessment just form to go through, and I don't even mean the physical form, just a process to go through, it makes it so much easier to get mentorship. If I go up to one of my old CIs or something, and I go, well, I think I felt a left rotated blah blah in T7 or something. If I approach them that way, they go, well, did you really feel it like that, or this kind of the other thing? Whereas if I go up to somebody like a CERT or a DIP MDT, and I go, well, I got my history down. Things indicated that she doesn't like bending. She doesn't like sitting for a long time. Walking's okay, yada yada. We go through a bunch, get to the repeated movement section, and I present what's there. If it doesn't make sense to me, it's standardized. I mean, this person that I'm asking, my mentor, he's probably done this a zillion times. He's seen this patient presentation before. He can give me at least an idea of where to go. Maybe it's not the right one. Maybe it's the wrong one. I don't know. Yeah. But he can go, well, why don't you check sustain for a bit? Great. Perfect. Yeah. And that, trust me, that's happened multiple times for me. So
we could do a whole video, I feel like, on sustained postures.
I think we're gonna have to,
because that's a huge misconception and a huge lack in what most people, I feel like, do in MDT.
Well, I think that's a pretty good note to leave on for this. Coming up, we're actually gonna have a part 3 of this series as well. We're gonna talk about why we like to do what we do. So this video is maybe a little bit more so why we don't like to do other things. The last one, we're gonna really go into some of the research of why we like to do what we do.
Move your patients early.
You better move them often.
And move them to end range, my friends, because that's where the magic happens. See you next time.